Hello, everybody, and welcome to Good Tech, an ongoing discussion around ethics and technology. I'm Elizabeth Perry with Idka. As a reminder, this show is recorded and will be available on the Idka YouTube channel, on ubngo.com/goodtech, and on iTunes or any other podcast platform you choose. If you're joining us live today and have any questions or comments, we'd love to hear from you. Dial the US number on your screen, and we'll do our best to get you in on the conversation. If you're shy but still have questions, find us on idka.com and we'll continue the discussion there. So today's show is entitled For the Health of It, a look at healthcare in the digital age. We've all got to face healthcare and take care. But what about privacy? What about data leaks? What kinds of things should we be looking for or out for or doing to protect our privacy while managing our health? And when, if at all, should we share our information? Here to help us tackle those questions and a lot more is someone who has experience in healthcare and technology, who works at bridging the gap that often exists between the two domains. There's been a lot in the news, so we've got a lot to talk about. Please welcome strategist, futurist, privacy and cybersecurity expert, and chief privacy and regulatory officer with Omada Health, Lucia Savage. So Lucia, it's really nice to see you on the show. I know you have experience doing this and we've got a lot to talk about. So it's really nice to have you. Welcome.
Thank you for having me.
All right. So I am getting already people asking questions because a lot has been in the news lately. But first I want you to, if you could describe, what I love is you describe yourself on LinkedIn where we kind of met as, and I love this, for one, because we're, after all, talking about ethics and technology. You describe yourself as architect of bridges between tech and healthcare. What do you mean by this and what brought you here?
Sure. So I want to describe what Omada Health is briefly, and I think that will give a context for how I do what I do. So Omada Health is a healthcare service delivery company. In the American scheme, we are literally just like a doctor's office, only the way that we provide our services is we use a secure, regulated technology platform through which trained healthcare professionals communicate with individuals that are their equivalent of patients in an asynchronous way. And that platform allows Omada to collect digital signals that those people want us to collect about their life. So an example would be our coaches help people manage type 2 diabetes out in the world. Instead of going to a doctor's office once a month, you're in daily contact with your coach. Your coach is seeing what your glucometer, your digital glucometer is saying, your glucose readings are. You can get real-time input about a high glucose reading because you're at a party on New Year's Eve and you drank too much alcohol, for example. So it's all right in time. And for me, I've been in healthcare 100% of my job for almost 20 years. And I really believe in the power of these digital signals to make our healthcare professionals smarter, better, more accurate, more relevant to each patient they see. And Omada is building that model. And so that's one of the reasons I joined Omada. But in my role here, I have several functions. And to the architect of bridges, part of my job is making sure our engineers and product designers understand why the healthcare rules operate the way they do. And the corollary is also true to explain to regulators and people who are healthcare traditionalists how tech can actually fit in traditional healthcare and make healthcare better.
Okay. So yeah, we're going to talk a lot about that bridge. So in the news, let's just start off with the news.
Diving into the deep end of the pool.
Let's just do it. So Google, and this is pretty important stuff here. Google and the 2600 hospital Ascension Health System are collaborating on an effort they're calling Project Nightingale that puts identifiable patient data in the hands of tech giants engineers for use in projects on machine learning and AI, or augmented intelligence or artificial intelligence. What is going on with that, and what are the potential problems, or are there any problems with what's going on there?
So I don't know anything about that except what's been reported in the press. So I'm going to respond based on public reporting, but I have no, insider knowledge.
Sure.
So the first thing to say is in the American system, and this is not true in the same way under GDPR, but in the American system, healthcare institutions have always been able to hire data analysis firms to help them, always, since the rules were enacted almost 20 years ago. And there's some really famous companies that do this for pay. Optum is one, owned by United Health Group. IBM Watson is another one, famously tried to do cancer analytics for MD Anderson. And so Google is just joining that fray. That permission that these big institutions have to hire analytic assistants has a bunch of rules. They're not too complicated for someone like me who does it for a living, but they might be a little bit foreign for somebody who's unfamiliar with them. And Google has said they are doing this by the rules. So among the rules are things like the people handling the patient identifiable information have to be distinct and segregated from the people, for example, handling all the rest of Google's business. The people handling the information have to have access based on their role and their need. And then the work that Google's been hired to do has to fit within certain regulatory permissions. So all of that is really constrained by regulation in the US. And although the government has announced it's investigating the relationship, like I said, Google and Ascension have been very adamant that they're following the rules. And those rules are already used every day by many, many other organizations. So that's one thing. The second thing I'll say is in the American system, we've been really successful at getting more physicians to use electronic health records and more hospitals to use electronic health records. 10 years ago, we started at about 50% penetration in hospitals, and now we're close to 97 or 98%. So if you're a system like Ascension's, you might have several different EHR vendors across all of your facilities. And those EHRs, the way they talk to each other, it's not a modern tech stack. We'll just be honest about that. And so, for facility A in one city to know what happened in facility B in another city as patients move around, maybe a search function that's modern is good. Maybe it's a good idea to build a service layer that's search oriented so people can find just the information they need and not too much. Because what we hear from the doctors is the interfaces are overwhelming, the design is terrible, they can't find what they need, or when they find it, it's buried in a bunch of stuff they don't need, right? And our chief medical officer has tweeted, it would be kind of nice to have a really precise search function for an EHR.
Right. So there's a lot of back and forth with this. One thing I've read is that patient privacy cannot be retrieved once it's lost. So the AMA has made protecting patient health data in digital age a top priority. Go ahead.
Well, I was going to say, I think in America, we're having a very vigorous debate about privacy, and this is a little bit of an inflection point in this issue. It's very clear that America, we don't have a countrywide consumer privacy law like GDPR is. We have different privacy laws for different economic sectors. And as our uptake of tech has grown and the Internet of Things has become ubiquitous, the gaps in that approach have become apparent. And one only has to look to congressional testimony, all of which is online, to find people, literally the big tech companies, Google, Apple, Microsoft, credit reporting bureaus saying, yep, self-regulation for the last 2 decades hasn't really worked. We want you to enact a law. And then the argument is about what that law looks like. So that is all that that Google Ascension, AMA, and whoever else is involved in this discussion is all happening in a bigger context. So
Right.
a key thing here is to really solve the issue of how are consumers best protected from a privacy perspective in the States, we probably need a new law. And that conversation has to be taken to Congress. So, whether the AMA or a tech company or a consumer organization, that's where the dialogue needs to be. That being said, I will tell you, the AMA is an Omada customer. We have a very good working relationship with them because where we align is that we want tech in healthcare to be clinically efficacious, easy on the doctor, appropriate for the patient.
Right. Right. And we're going to get into a little bit further. We're going to get into sort of, the relationship between privacy and consent.
Okay.
But so I want to, speaking of tech, there's another piece of news that I thought was interesting. Maybe you'd like to talk about is wearables.
Okay.
Wearable tech like Fitbit or, whatever else is out there. And researchers are warning that wearables have, a lot of negative repercussions. Data could be used to penalize policyholders with higher premiums or to deny insurance. The readings could be inaccurate. I mean, we know that in China, for example, a lot of people have to wear wearable tech in their jobs so that people know that they're healthy.
Right.
Just anyway, so and we could go on, but privacy is at risk. What do you think about that?
So there have been a couple of stories reported in medical-oriented journals lately that they do call out this potential gap in privacy, which I referred to in my prior question. But I worry that those articles have a bit of hyperbole in this way. When I dig into them, what I notice is that the researchers read a privacy policy, but they're not bringing the attorneys of whatever jurisdiction to the table to really understand if there's a reason the privacy policy reads the way it does. And if you were to line up a health app or European-based wearable privacy policy or Israeli-based wearable privacy policy with an American one or an Australian one, you should see differences in those policies because each of those countries has a different environment in which that data collection is occurring. And until you start accounting in your analysis for these legal differences, you're going to reach the wrong conclusion. It's sort of like treating self-help as medical practice. You can say that outcome is X and outcome is Y, but you have to really account for the clinical environment in which that happens. And so that's what I would hope is this is an opportunity for really close collaboration between medical researchers who are concerned about patient privacy as they should be and as they are required to be by the Hippocratic Oath, and the legal privacy experts in whatever jurisdiction that can say, well, this works this way because of that, etc. In fact, here at Omada, our chief medical officer and I blogged about this, I'm going to say 3 months ago. Anyway, it's on our blog page. It's sort of like some apps or wearables have really robust privacy policies. Omada is app-based. We have a very robust privacy policy. We never sell data, and some are not. And the consumer really does have to start paying attention.
Right. And there's so much in the news and about, the selling of data, the sharing of data with big tech firms that use it to, they mine people's data because It's an ad tech model. That's what they do,
Right.
But I'm going to there's a quote along, with the wearable tech question. Researchers have written that adding that data collected by a wearable device is not protected by the Health Insurance Portability and Accountability Act, which is that's HIPAA, right?
Yes. So that would be true in the States for consumer app. And that's part of what I'm saying. So Omada's model is using an app so that the patient can access the secure platform where the professional is, right? So it's app-based, but it's actually within HIPAA, right? Whereas a free weight loss app that you might show up in your Twitter feed that you just click on that may or may not be true.
Right.
And so in America, where that app sits in our legal constellation is very important for privacy. And the researchers in the JAMA article didn't account for that.
Mm-hmm.
So not everything is terrible. There's actually some really great technical services for people. There's Omada. There's a company that's sort of using our model, but for in-home cardiac rehab. Again, they have a secure platform that's squarely within HIPAA. Obviously, they're apps supplied by your physician's practice, so you can communicate with your physician. Those are squarely within HIPAA. So it's really not the parade of horribles that article implied, but there are these differences and they're well known. In fact, I would say, and people who are interested can get it, it's a pinned tweet. When I worked for the government before joining Omada, one of my tasks was to write a report for Congress about this exact problem. So the link to that report, which is a public document, is available on Twitter. And the nice thing about a report issued by a government agency is it's 100% accurate. There's no hyperbole. So many people read it before you get to send it over to Congress that there are no errors in
it. So you're saying that it's not as bad as we think.
I'm not saying it's not bad. I'm saying that there are beneficial health apps that have really good privacy practices, and consumers should use those.
So we have to do our homework, basically, is what you're saying.
I think for now we have to do our homework. In the U.S., if we had a different consumer privacy law that created more kind of background rules and made it raise the bar on behavior in a way that freed you from checking out every terms of service, I think people would feel a lot better, but we don't have that right now. And that's what this current congressional debate is about.
Yeah. And I think that brings up another point that, have you ever read these privacy policies?
It's like, oh yes, I've read a lot of privacy policies, including, my own app set. And, just Tuesday was World Data Privacy Day, and there was a whole Twitter string, what should you do? And my comment was, check your app settings to make sure they're still what you want them to be, and then teach a friend how to check their app settings. When apps update, it can override your settings and revert you to the default, and people don't know how to check their settings, and or add-ons to do ad blocking, all the things you can do to manage whatever apps you're using. And yes, I am on social media, and I understand exactly how public that is.
Yeah. I, for one, think that those privacy policies were written for lawyers or purposefully misleading or just, I don't understand half the things as they're saying.
They do run the gamut. And I will tell you, at Omada, we just updated all of our policies because we had to for legal changes. And we actually have to notify all of our people. So that's hundreds of thousands of notifications. And we did get a few people who wrote back and said, wow, thank you. This is so clear. I actually understand it. So I wrote most of them. And what I didn't write was written by another lawyer at Omada. And it is possible.
Yeah. Okay. All right. Well, I have hope then. So let's talk about communications in healthcare. When you talk between patients and doctors, or doctors and doctors, or doctors and innovators, or what do you use, for example, at Omada for communication?
So we have built our own proprietary secure platform for our professionals to talk to our individuals. We also have a bunch of sort of satellite services, for example, through our customer support unit and other things that create security in the communications, because we know that as an individual or participant is communicating with us, or we're communicating back to them, we're a healthcare organization, there's going to be health information in there. We want to secure it as best we can. We also know, however, that most people, they're getting an email from us that we send out securely, and it's just dropping in whatever their commercial email box is. And so that's something I think the healthcare system has to really wrap its head around, which is there is a point in the communications chain where responsibility falls to the receiver, in this case, a consumer, to manage their form of communication versus the person who's sending the communication. And It can be, does a person use Signal or another secure messaging app, or do they have, a Hotmail account, just to draw a contrast, right? Do they use two-factor authentication on their phone, or do they use no security on their phone and let their kids play with it all the time? Like, those are things the healthcare provider just literally can't control. And we have to assume that people are grown-ups. When in the US, when we have banking, we don't dictate how people manage their own money. We say, if you're going to put it in a bank, here's some rules the bank has to comply with. But if you want to cash every paycheck and stick it in a pillowcase in your house, you are free to do that. And nobody prevents you from doing that.
Right. So, just bringing up Idka, for example, we're a platform that is a secure environment where you can share, you can connect, share, and store anything you want. So it's like a walled garden almost that we used to have back for the millennials. That is actually a place where you can communicate and it doesn't get out. Information doesn't get out. So we provide rooms and chat and notes and storage all built into every relationship that you have. So that might be a good opportunity for, and we do have healthcare on our radar. And that might be a good type of thing that you could use to either, in hospital administration or with with not parents, patients and doctors. I mean, would you recommend something like that rather than just a chat app or, like you say, mail?
I don't know, because I don't know enough about the platform. I can say this. I know that two things. Patients very much want to be able to have quick smartphone-based communications with their physicians. And at least in the US, because physicians may or may not get paid for responding to those communications, there's definitely some resistance to that. We haven't figured out the mix of on a kind of a standardized way for physicians and patients to communicate and for it not to be a burden on the physician. Physicians have different practices about that. Some refuse, for example, to email patients. Other physicians give their Gmail accounts to their patients and they have communications that way. And the law allows a patient to say, I get it, Gmail may not be secure, but I know what I'm doing, which I think is fair. Patients who are adults should be assumed to know what they're doing. And so I think people really have to pick the platform that's best for the relationship those two people have. I wouldn't want to force a particular platform on physicians, nor would I want to force a particular platform on patients. Patients want different things. Consumers, just in the US, right, 340 million people, that's a pretty diverse group of people.
Right. So on to, let's see, we talk about the issues of privacy in healthcare. We really need to address two sets of people. Actually, really more like four, but one is consumer or patient, and and then the other is provider or innovator in healthcare. What are some of the challenges? It's a big question for the innovators in the industry.
So I think in the US, like I said, I sort of think we're at this inflection point. I think we've had a period of time in health tech innovation where there's a branch of products and ideas that are trying to specifically stay into this low regulated consumer retail space. So just think direct to consumer, not billing, not healthcare, maybe not even supplied by a provider. And then there's another branch of people like Omada that are trying to actually change the healthcare delivery system and stay squarely into healthcare. And so we've done a lot of work in that space, and our view at Omada is healthcare should embrace digital tech for clinically efficacious services, because once you're in the healthcare system, a lot of things get solved. How do you account for fraud? How do you bill? The privacy rules just kind of click into place automatically. But different people choose different business models. So I think for an innovator, the first thing they have to think about is their idea compared to their revenue model, and how are they going to make money off of their idea, because there are definitely two distinctive branches in the US. In Europe, that's not going to be the case, because in Europe, the regulations follow the data, not the economic sector. And so you may be a health tech company in Europe and you may fit into some specialized GDPR rules for healthcare providers. For example, if you're a doctor who sponsors an app and you're connecting to people, but it's quite a different environment. And that's why I gave that example earlier of Israel versus Europe versus Australia versus the US. I could throw Brazil in there. They have a new law. Different countries are actually standing up rules that they think are appropriate for their populations, and innovators worldwide really have to think about, what's my idea, where am I going to do it, how is it going to make money, and the way I want to make money, how am I going to comply with whatever laws apply to that method. So one more thing I was saying, in the US, the Federal Trade Commission, which is the general regulator overseeing the consumer tech world, actually has a really great tool on their website that's multi-agency tool about how does an innovator decide which law applies to its idea. It's called the Mobile Health App Developer Toolkit. You can just go to the FTC website and kind of click on Mobile Health App Developer and it'll pop up and it's like, are you building a device? Go to this agency. Are you building like literally a Q&A that kind of drives you down a decision tree to your endpoint. And it's free.
And sorry?
It's free.
Yeah. Okay.
Free to use, so.
But privacy has got to be baked in to any health related app. Well,
I think that's right from an ethical perspective, but I think the law has these gaps. And so that's what we're trying to solve for as a society. A really great example is medical devices. So in America, a medical device, which may have software in it, by its very standalone, not connected to a hospital, not connected to a doctor's office, just the device, may not be subjected to our normal HIPAA privacy rules. And the agency that approves devices, while they're very interested in privacy, the Federal Food and Drug Administration, actually doesn't have legal jurisdiction to dictate privacy terms for a device.
Oh.
When that device is in a hospital, connected to a patient, feeding information into an electronic health record, of course, that hospital is within HIPAA, the electronic health record is within HIPAA, the medical personnel are within HIPAA. So that's always been the assumption. But now with the Internet of Things, we have devices that are subjected to FDA oversight for safety, right? We don't want to have people wearing a wrist tracker that's unsafe and is going to electrocute them, for example, but may not connect to the healthcare system at all.
Right. Yeah. So this is, this is more complicated than just, but let me just get to, I mean, we all know that privacy is important in healthcare, but there's a line, right? I mean, there's a line that gets blurred between sharing of information for the health, for the health sake of people, and keeping it private for other reasons, insurance, whatever. So where does that line get blurred? I mean, I want to read a little quote by Judy Faulkner, founder of Epic, one of the largest providers of electronic medical health records. She warns that a proposed rule on information sharing could create a Cambridge Analytica-style situation where the data of a patient's friends and family is shared without their consent. And then there could be all kinds of problems with that.
Right. So I will say that I disagree with Ms. Faulkner and have done some tweeting about it and some writing about it. And I'll tell you why I disagree. So that situation basically already exists, right? Nothing prevents me from going on Facebook and gossiping my entire family medical history all over Facebook right now without my family members' consent. Like that just is, right? And that happens in human discourse. Without Facebook, you might go to a cocktail party or a potluck or a picnic and end up talking about friends and family and health conditions. So that already happens. And so that's one. And two, Ms. Faulkner is claiming that the ONC rule itself will cause a privacy problem, but the gaps in our privacy regulation in the US exist whether ONC issues a rule or not. As I've kind of described, they exist, they're longstanding, they've been around for about 20 years. The Internet of Things has grown up around them. There's a lot of disagreement about what Epic has said. It's been reported that other large EHR vendors, Cerner and Allscripts, are not in agreement with her. Obviously, there are, ardent advocates for the patients themselves who think this is wrong. And I think there's a lot more to be said about this. And I'll just give two examples. In the Society for Participatory Medicine, which is an organization here in the States where patients want to be aggressively participating in their own care, has issued a blog, I'm going to say Friday or Saturday, in which they capture the stories of about a half a dozen patients. So one of the patients they highlight is a woman named Morgan Gleason, who's young. She's a millennial, or younger than that. She's 21. She has a rare disease. She has almost 24 physicians with almost 24 portals. And she wants to pick an app that's right for her to collect all that data together on her smartphone so she can track it. And when she, is traveling and goes to a new hospital, she can say, here's my health condition. Here's how my doctor at my home location treats me. And literally for some patients, this ability to have ready access to their own information can be a matter of life and death. And so we really have to think about, that's what America's been trying to build, is this interoperable system where wherever you go as a patient, the new doctor you're seeing there can find out what they need to know to avoid causing you harm as they treat you. And until we have interoperability, we're not going to have that. And we can't really have a situation that advances patient health when we keep the data in discrete systems and don't allow the data to go where it needs to go for care. So that's kind of the patient care side. And the other thing I will observe about this dispute about the ONC rule is it doesn't really address the problem that people raised about these big analytics firms, which is a different problem entirely, right? That's where, somebody hires somebody else to do analysis. And many of the EHR vendors have sister companies that do that kind of analytics, and they're not really talking about that. So if we're really going to talk about this and really solve this problem, we have to put all the issues on the table and decide if the system we have is working or we need a different system here in the States.
Can we just back up 1 second and
Sure.
explain for the layman what the ONC rule is actually saying?
Absolutely. And by the way, if people want to read more about it, I wrote a blog in Health Affairs last March, which kind of summarizes it. Okay. So it's a little bit complicated, but 2009, the government decided to put more than $40 billion into incenting physicians to use electronic health records. So that was almost 10 years ago now. And we did that. It went from 27% at the doctor level to about 90% and 50% hospitals to 97%. So now we have this very rich clinical data set. The problem is that the EHR vendors themselves were making it very expensive and technically complicated to connect to each other. So I'm just going to pick on Ascension because we've talked about them. I'm making up facts. I know nothing about Ascension's business, but if you have one hospital that has Allscripts and a different hospital that has Epic, and you have a patient that moves between them, maybe for legitimate clinical reasons, those two systems weren't talking to each other in an easy, affordable way. Moreover, patients couldn't get their data out of the systems themselves in electronic format. They would these piles of paper and, not very meaningful. So in 2016, on very strong bipartisan grounds, the US Congress passed a law, 21st Century Cures. And in that law, they outlawed something called information blocking, which is basically not letting the data flow to an unaffiliated company or an unaffiliated EHR. And then they asked ONC, one of the federal agencies, to write a regulation that detailed in much more detail what information blocking meant and what were allowed exceptions to the prohibition. Following me so far?
Yes.
Okay. So that's this rule. And the essence of the rule has two main parts from a privacy perspective. The first is it will require the EHR vendors to build an application programming interface that uses a open source public standard, the Fast Health Information Resource Standard, or FHIR, or Smart on FHIR, so that the app developers can program their apps to make data calls using a non-proprietary specification. And the second piece of that particular part of the rule is that you, Elizabeth, would then be able to pick the app that's right for you, make sure that app had legitimate identity credentials for you, and make a data call on your doctors to collect your data to yourself. So Apple Health Kit does this already with most EHR vendors. If you have an iPhone, you can load the Apple Health Kit app, go through the process of authenticating yourself and pull your data yourself. I've seen it happen. It's kind of slick. Android needs to catch up. So that's part one of the rule. And then part two of the rule has some other features about all the ways that, what can be charged, when can you reject an app because it might be causing security threats to your system, when does privacy override this data call that's being made, et cetera, et cetera, et cetera. So a lot of detail in there. And the rule is due to be published in final any day now. But obviously lots and lots of debate about that. Just today, there was a letter in support of the rule issued by Pew Trusts, and about 85 people signed on. So that's being reported in the press. Obviously, there's been a lot of reporting about where different tech companies fall in the universe. And so more to come.
Yeah, and I can see where it's a heated debate, but I can also see where there's a real need for education, for the patient that needs to know that, hey, if you use this app, you might not be as safe as if you use this app. So yeah, maybe it's not a responsibility on the side of the healthcare professionals, but maybe it needs to be talked about, or literature or some.
Interestingly enough, the rule actually has provisions for, what happens when a physician or system wants to say, I like these apps better than those apps, and when is that legitimate versus illegitimate. But again, the idea, and Don Rucker, the national coordinator who leads ONC, has been very clear that we need to treat adult patients like adults and let them manage these things for themselves. And I happened to listen to Morgan Gleason, that very sick young woman, talk about her struggles. And, she was really clear that she understands how the internet works and she wants to use an app that's right for her.
Yeah.
For anyone who's a world traveler, right, you actually might want to pull all this data to yourself, have it on your phone. If you get injured on some far-flung place that's not in the American healthcare system, you might want to say, here's my health data, here's my allergies, here's the medications I'm taking, here's why you can't treat me this way because I have this condition, whatever it is, right?
Right. Yeah, that makes, I get it. Interesting. And we're all going to read more on
Yes.
that, I'm sure, because it could go, that could be the whole show.
Right. Exactly. Anyway, there's lots of reporting, and I would urge your listeners and watchers to make sure that they're looking at both sides of the story, because there's definitely a wide array of opinions. And, as I said, one EHR vendor has raised one set of concerns, and the other two have not raised those concerns. And that sort of that itself is interesting.
Yeah. So, just let's get back to the patients, and sort of, you're a wealth or fountain of knowledge over there. And I think people probably want to hear some tips or, some opinions on other things. And we were talking about social media, and I was talking with the moderator of a Facebook group, a health related sort of support group for a pre-existing condition. And I just sort of mentioned, because I work with Idka, that, why are you sharing such sensitive information on this group? What are the risks of doing that on social media? Because my understanding is, even if the group is private, you're still letting go of a certain amount of information, at least, to Facebook.
Yeah.
For example, go ahead.
If you don't mind, I'd like to actually start with the benefits and suggest that you have on your podcast a former colleague named Susanna Fox. But the clinical literature is very, very clear that there is significant health and emotional health benefits for people either managing other people's conditions or with conditions themselves in a peer support network. And this has been true for decades. We know this. And social media has just created some new avenues for that to happen, right? Because you may not have critical mass of 10 or 15 people in your community, but you can find 10 or 15 like-minded people. In addition, there's a further benefit, which is through social media, people with super rare diseases, like, 1 in a million, have been able to find each other and create really important pods of patients that can collaborate with researchers to find cures.
Mm-hmm.
There's some really important benefits to this change in the way we do peer support groups. That said, there's been a lot of reporting about different social media sites, and I think that I'm just kind of going to repeat what I've read in the reporting. Some social media sites are specifically designed using, design techniques to make it easy to use. Facebook would be one, WhatsApp would be another, Instagram would be a third, although I don't think there are health groups on Instagram, but I'm not an Instagram user. And so there's actually kind of like a critical mass of people in these groups, right? So then now the group has a problem of, if we want to migrate, how do we migrate the whole group? So that's not just a technical problem of migrating your data or your information from one platform to another, but migrating enough people to keep the critical mass of the beneficial effects. So it's very complicated. I think that, slow progress is being made. Obviously, in California, we have the California Consumer Privacy Act, which gives data portability rights to people. And obviously, Facebook and other platforms have said they're going to comply with those data portability rights that are inherent in GDPR nationwide. So there is some portability, but that just lets you port your data. It doesn't necessarily give you personally, right? But if you need a dozen people or 100 people or 1,000 people, how do you get them all to go with you, right? That's a logistical problem. So there's that. So what I would say is, most consumers, I think, have a higher understanding of what is actually happening on social media platforms and how ad tech works right now, and that people should just be really thoughtful. So I'm going to make up some facts based on some stuff people have told me. But if you have a rare disease and you want to keep it private, but you want to talk to your cousins on social media, you have to teach your cousins not to talk about your disease when you're dialoguing on social media, right? You could easily control what you say about yourself. I don't put my health conditions on social media, but somebody else could write about me because they know me. So it becomes a process of educating your network about maintaining your privacy,
right?
Your immediate network. And then lastly, for the big health groups, I think they have built trust with each other about how they're going to be used, as long as the participants are not there under false pretenses.
Right. I mean, I guess, because so I'm just going to play the other side here and say that, Facebook owns your information, basically. They can do what they want with it. It's written in their fine print.
Yes.
So if you say, for example, join a private group for cancer awareness or breast cancer support group or something like that, that information, just the fact that you're on that group, and along with the number of people that are on that group and other people that are on that group, you could imagine a scenario where they could sell your data or share your data with insurance companies.
Yeah.
That would then not cover you or something.
Well, so there's two things that are really important to break down. Remember, in America, since the Affordable Care Act, we don't legally allow insurance companies to reject you for health insurance, for health conditions. It's just not allowed. It used to be a big problem, and we passed a law to make it not a problem. That's the pre-existing condition fight. And it may become a problem again, depending on how politics unrolls. But currently, federal law does not allow an insurance company to reject you for health condition. They can charge you more or less within underwriting guidelines, but can't reject you. That's different than life insurance. Those rules don't apply to life insurance or disability insurance or other kinds of insurances that might be in the casualty side, but implicated by a health status. And most people probably don't understand that distinction, but I wanted to really call it out. And obviously the pre-existing condition issue in US is very hot topic politically. Just, type pre-existing condition into Twitter and see what happens. So that is the state of the law right now. You shouldn't have to lose insurance because you disclosed your health information, but you may charge more, or the insurance company may say, you didn't tell us about this condition, and so now we're going to charge more, because of course you can't lie to your insurance company, right? You shouldn't be lying to your insurance company. It's fraud.
Right.
So I don't know if that assuages people's concerns or not. I think that people do worry about it for life insurance, for employment discrimination based on health status, which again is illegal, but you have to prove it. So for people who are in the health support groups on social media, it's really important to think about all this stuff. I have friends with very significant illnesses who do not participate in those groups because they don't want to. And I have other friends who find them super helpful. And for them, the understanding of how Facebook works with ad placement is more valuable than they've made the trade-off in their minds, if you know what I mean, right? They've done the calculation and decided what's right for them. Again, treating grown-ups like grown-ups.
Yeah. But I do want to say, I do want to put it out there that there are other platforms where you can communicate and join. Idka is one of them.
Right.
I'm just going to, do a little push for Idka because it's a private network. It respects your privacy.
Yeah.
You can communicate with big groups, and it's all encrypted, and we don't share or sell data. So
I don't, I'm old enough to remember when I paid for email. And I would be happy to pay for email again, but not everyone can afford to pay for email, and pretty much everyone needs an email account. There are so many, there's such an array of choices and decisions that people have to make as they manage their private information in this ubiquitous internet world, that it can be overwhelming, and it can be complicated, and you can just want to, go home and watch, whatever reality TV show is amusing you this week.
Yeah.
I hate to say it, but people do have to, just like their finances, people have to take personal responsibility, and there are going to be a wide array of ways people do that.
Right. So I just want to, since we only have a few more minutes, of course, that means you're going to have to come back on the show. I hope you will join us. It's been fun so far. So again, another social media exchange. I thought this was interesting with regards to big tech. Suddenly big tech is pushing for more regulation, higher regulation, greater regulation of privacy, that kind of thing.
Sure.
Someone actually said to me that big tech is doing that because that allows them to control smaller tech, like doctors.
Yeah. So I don't know. I have not heard that. I mean, I definitely think there's always been a dialogue about small disruptors and big companies. And you should have a whole show on tech and competition, because that's actually kind of a different topic. What I would say is that in the States, the reason the big tech companies are in Congress asking for a law is because they want the same law in every state and territory. So it's 50 states, 6 territories. They want the same law everywhere. California Consumer Privacy Act is an example. Nevada passed a law. Washington State, New York have bills. So what's really, really hard for business of any kind, whether you're little or big, is to manage a different law every place you might have a person.
Yeah.
And tech has both employees and users everywhere. And so that's why there's this dialogue about, can't we have something nationwide so it's the same everywhere? Because that's easier to manage your systems when the guardrails don't change.
Yeah.
So that's the basic force of that.
The example that this particular person brought up, I thought was interesting because it had to do with the cost of compliance, and that large health organizations can afford the cost of being compliant and paying the fines when they're not compliant. Whereas you don't have the smaller groups of doctors or the private doctors as much. What do you think? Does that not ring a bell?
So I would say 2 things about that. Let's separate the doctors as a small business from a tech company entering health. So doctor as a small business The rules that apply to that doctor's office are designed to be scalable and designed to relate to the specific risks that doctor's office presents. For example, nobody's required to bill electronically. If you're a doctor who bills with paper invoices, the rules that apply to you are sized for that activity. Whereas if you are billing electronically and creating this electronic data, different rules kick in, one. And two, the government has spent tens of millions of dollars. I used to manage part of this budget, creating super easy to understand educational materials just for these small business physicians' offices. AMA has done a great job as well. And, whether the physicians take that up or listen to consultants, I don't know. I do remember answering a letter for Secretary Burwell where a consultant said, please take that free tool down. It's eating into my revenue model. And I said, no, the taxpayers paid for this. We're going to keep it up. So that happens. For tech companies, again, there are a bunch of tools, and I'll go back to where we were, 45 minutes ago. You have to kind of figure out where you fit in the universe that is the healthcare system in the States. But I would say, Omada, we're 8 years old. I've been here 3 years. There was a privacy officer before me. Of course, they invested in the salary of that privacy officer, but they intended to build compliance from the ground up, and so they didn't have to retool. And nobody here has ever said to me it costs too much. In fact, we have a great security program, a great privacy program, and it makes us able to sell our services to people confidently. Mm-hmm. It's a brand distinctive positive for us. And so you got to think about that too. If you start down the direct consumer path and you decide to go into healthcare and sell to a health plan, yes, you're going to have some requirements for that health plan. If you didn't plan for those, it could be costly to retool them.
Yeah. Well, we're sadly out of time today, but I do want to wrap it up with some final thoughts. We have a group on Idka called Privacy 2020, and we talk a lot about the issues surrounding privacy, and healthcare could be one of those things. I'd love for you to just say a few words for our group, and what kind of final thoughts would you like to leave our audience with?
I will leave the audience with this, which is it's really important to remember that a consumer cannot get healthcare without actually sort of being compelled by circumstances to disclose their most intimate details. And in traditional healthcare, the doctors collect that really in a great deal of trust that's built into the Hippocratic Oath. Literally, it's in the Hippocratic Oath as a clause. And so if you are going to be like a doctor, you have to think like a doctor relative to, my patient had to tell me this intimate detail that they had an abortion, that they had a sexually transmitted disease, that they're going through gender transformation, whatever this intimate detail is. And it's my job is to take care of them, not to reuse that information for some other purpose. That's the really important ethical piece here. And that is why sort of we have the privacy system we have in the States, and we should hold that up as our North Star as we think about health tech and privacy.
All right. Thank you so much. Lucia, it's been a real pleasure having you on the show today, and I do hope you'll come back because we didn't even scratch the surface of some of this stuff. And next time I'll have it maybe focused on one area of health tech because it's fascinating. So Thank you so much.
Yep.
So everyone else, our audience today, thank you so much for joining us. If you like what you've heard today, please share the love and share or follow us on Twitter at IdkaAB. Lucia, you can find also on Twitter. Lucia, it's I forgot.
At Savage Lucia. Pretty simple.
At Savage Lucia. Thank you. We're also on LinkedIn, Instagram. Be sure to visit idka.com, set up a free account. In just a few clicks, you can communicate, collaborate, and share with the people that matter. For ongoing discussion around privacy, look for the open group, Privacy 2020. Any questions for me? I'm always happy to chat. You can find me on Idka or social media as well. Thanks to all of you again for joining us. Have a great morning, afternoon, or evening, wherever you are in the world. And we'll see you on the next Good Tech. Bye.